So, chapter 4, pain. What is pain? Pain is a symptom, not a sign. It is a sensation. It is uh, different for different individuals. It's an unpleasant sensation. And it's really just caused by anything that stimulates pain receptors. Pain is a very important thing. Uh, if you've ever watched Grey's Anatomy, there was an episode with a kid that couldn't feel pain, and it was interesting about all of the kind of physiological trouble she got in because she didn't avoid uh, situations that were causing her damage. So it's a warning mechanism. It warns of problems of tissue damage. It's very complex. It is a major subject for healthcare because people don't like being in pain. Managing pain is a huge priority uh, in healthcare. Um, we don't quite understand all the mechanisms involved. There's some very good theories. There's some good practical things, but the completely understanding is still eluding us. Um, One of the big things, because so much money is spent in managing pain, uh, insurance companies and third-party payers, et cetera, don't really like symptoms. They like signs. So there's been a big push to kind of quantize pain, and so that you can compare pain levels, so that you can, you know, are you 5 out of 10 or a 9 out of 10 on the pain scale? That kind of thing. Um, but it's so subjective that it's almost meaningless. There's so many other factors involved. So inflammation causes pain. If you remember, one of the primary, like the five cardinal signs of uh, inflammation, PRISH, the first one's pain. Inflammation and pain go together, and any tissue damage causes inflammation, which therefore causes pain. Infections, ischemia, necrosis, uh, deformation of the tissue, stretching of tendons, joints, ligaments, joint capsules, uh, all to it. Burns, muscle spasms cause pain, um, things like that. We divide pain into somatic pain and visceral pain. Somatic pain is from skin and bone and muscle. There are sensory fibers that go from pain receptors in the muscle, in the bones, in the skin, and uh, go to their central nervous system by these sensory fibers that are dedicated to this. Because, quite frankly, these are the things that you need to avoid. Right. Visceral pain is different. This is the pain that happens in organs. There, it's not as well localized. It's not as well defined. Uh, Usually, it's not along dedicated pain fibers, but along sympathetic fibers. So it's less localized, and oftentimes there's referred pain. Pain in both can be acute or chronic. Uh, yeah. So NOCI, NOCI means pain. So the receptors to pain are nociceptors. They are uncomplicated, just simple nerve endings of these sensory nerves. Things that set them off are really pain mediators. It could be extremes of temperature. This is not through the cold and heat receptors, but through the pain receptors. And usually the extremes of temperature have to cause tissue damage in order for it to become painful. Um, Prostaglandins and histamine, bradykinins, are all chemicals that will set off pain receptors and cause pain. And if you take note of that, these are all inflammatory mediators. Um, Acids cause pain. I mean, classic lactic acid buildup in muscles is a painful thing. So this doesn't just mean acid that's spilt on you, but acidosis or acid in the tissue. Um, Physical deformation of tissue, pressure uh, can be quite painful. But when we're talking about pain, because it is subjective, we have a couple of different uh, definitions to deal with: pain threshold versus pain tolerance. So, pain threshold is the level of stimulation required to elicit the pain response. And that's pretty consistent amongst individuals. So, it's the amount of pressure to stimulate the nerve ending, it's the amount of prostaglandin, the amount of inflammation, the amount, like, it's the stimulation required to actually trigger the nociceptors to send the signal along the afferent pathways that where you perceive the stimulus as painful. What you do with that after you receive the stimulus is about tolerance, uh, your ability to cope with pain. Uh, it's There's a history to this. Uh, some people are much better at coping with pain than other people. Uh, if the idea of coping with pain is in your family or in your culture, if that's a sign of strength, then you probably have better tolerance. It it varies amongst individuals, but it also varies with time or in the same individual. Sometimes you can cope, you have a better pain tolerance than other times. Uh, if you are particularly stressed, you probably have less ability to cope with pain. Uh, if you are distracted, if the pain's expected rather than unexpected, you can cope with it better. So, uh, like you're going to go to the gym and you know you're going to hurt the next day. Well, that's just the sequela of having gone to the gym, and you take the pain because it's indicating that you had a good workout and you can tolerate it far more than if it's completely unexpected from a different cause. Uh, so varies amongst individuals and it varies over time and situations uh, within individuals, which makes tracking pain a very difficult thing. Um, Oftentimes, when people are first injured, they don't have very much pain tolerance, but their pain tolerance for that pain grows. They almost start to adapt to it a little bit. It's uh, so it's not a reliable thing for self-reporting. People that say, "Oh, my pain is an 8 out of 10." 2 days later, the pain hasn't changed very much, but they might only report it as a 6 out of 10 because they've learned to cope with it a little bit. You know, those sorts of things. Uh, it it's worthy of thought and contemplation. Oftentimes, giving people coping mechanisms can really help manage pain, uh, managing their expectations of pain, managing the the stress involved with pain uh, helps. Like convincing people that the severity of pain is not connected to the severity uh, of the issue. Uh, For instance, I dealt with patients 40 years, people in pain. That's primarily my practice was based around pain management, uh, and I would try and convince people that there is not a correlation between the severity of the problem and the severity of the pain. And the example I would use is that if you hit your thumb with a hammer, you have a tremendous amount of pain, but not a tremendous problem. If you have pancreatic cancer, it's going to kill you in the next 6 months. You probably have hardly any pain at all. And so convincing people uh, that there's not that correlation actually helps with pain tolerance. It helps people cope because it takes the fear aspect out of it. It verifies that what they are feeling is normal to the situation they're in. Um, because when you're afraid, your tolerance goes way down. Okay, so whatever the stimulus is, it's going to stimulate these receptors, these pain receptors, and uh, and that's going to set off an action potential in the afferent fibers, the nerve fibers that are dedicated to pain. So there's fundamentally two types of fibers. There are A delta fibers and there's C fibers. The A delta fibers are myelinated. They have the nodes around there and they transmit impulses very quickly because they are myelinated. Um, they are useful in like withdrawal reflexes and removing yourself from the stimulus. If you were to reach out and touch a hot stove, those A delta fibers get to your spinal cord and your hand withdraws from that painful stimulus even before your brain registers that that was painful. And that's very important and very useful. The pain that you feel from a an A delta fiber is sharp pain and it's localized. The you can map it out on the brain to exactly it's the very tip of your right index finger, or that it's your big toe, or that it's in the in a spot on your shin, or whatever that local is. It's very localized. It's pinpoint discrimination. It's very quick to come on, and it's kind of quick to stop. The C fibers are unmyelinated. They're gray fibers. The action potential moves along them much more slowly, and they're involved with that dull, achy, burning pain. If if you were to burn yourself, you have a sudden, sharp pain that causes you to withdraw. And then it starts to throb and ache and and that's from the tissue damage. That's from the inflammation. Uh, if you waited until the inflammation caused pain before you withdrew, you would have more tissue damage. So these things are kind of, they both have their purpose and they both have their time. I I'll submit that I believe that the dull, diffuse, achy pain that lasts a lot longer is more useful for creating memories that that warn you against engaging in the same behavior. Uh, that is part of kind of the learning curve of that. Um, it also helps you understand the kind of the rate of healing and when you can go back to using those tissues, uh, you know, that kind of thing. So there's a there's this idea that when we're an embryo, as we are growing, we're a series of rings. Basically, early in the embryonic stage, we look like an earthworm or a whole series of rings called somites. And out of each somite will grow the structures that will become the adult structures. So if you look at a person, like the top of your skull is one somite, and then your brow ridge is the next ring, and then your cheekbones, your zygomatic, is the next ring, and then your upper jaw is the next ring, and your lower jaw is the one after that, and then the hyoid bone is the next one, and the larynx is the next one, etc. And then we get, and so each vertebrae kind of represents one somite moving down. And there's a pair of nerves for each somite. So the 12 cranial nerves, and then all of the nerves along the spinal cord, each kind of belong to a somite. And different structures grow out of the different somites. So the your arm grows out of kind of C5 to T1. And so all the nerves that go down your arm come from those levels of the spine. And we can map where those nerves end up, like in your arm. So for instance, your deltoid region, your shoulder moving down to your biceps is C5. That your thumb, index finger, and part of your middle finger is C6. So your wrist on that kind of radial side is C6. Your middle finger and the palm of your hand and up the center of your forearm is C7. Your your ring finger and your little finger and the ulnar side of your forearm is C8. Your armpit is T1. And we call those areas dermatomes. Uh, and they correspond with kind of this mapping of your body. Uh, there's myotomes, which muscles are innervated, and all of that, and we can really identify kind of problems with the spinal cord and that kind of thing, and reflexes all run along these dermatomes. We're going to see later that shingles, a herpes virus, uh, gets into these nerve roots, and the rash and the problem happens along these dermatomes. Uh, so really, they are a remnant of embryological development, neurological development in the embryo. Um, So one of the problems that we have, especially in localizing pain, is it's the same nerve that'll be in a large area. And so if the pain is not right at the skin, which is mapped more precisely, then the whole area, that whole dermatome will hurt or be numb or whatever. Um, and uh, and it can happen anywhere along that dermatome. So sometimes pain right at the vertebrae or a problem right at the vertebrae will manifest and feel like pain that is in your thumb, for instance, uh, because the nerve, that's where the nerve goes. Okay? Now, these pain sensors, these pain afferent fibers, they enter the spine and they enter the spinal cord and they ascend up to your brain along pathways that go from the spine to the central nervous system. But they also synapse right within the spinal cord with motor neurons, and they cause reflex action. So you automatically withdraw from a pain source, involuntary muscle contraction to withdraw from the pain source. At the same time, so that's called the withdrawal uh, reflex. At the same time, you have a crossed extensor reflex that goes to the other side of your body, so that if you withdraw the right side, you extend the left side to maintain your balance, really. If you were to step on a nail with your right foot, you you contract all the flexor muscles to pull your foot away from that potential damage or from that damage that started. And at the same time, you you activate all the extensor muscles on your left side so that you transfer your weight from your right side to your left side and you maintain your balance. It's the same thing that if you were to hurt your right index finger, you're going to withdraw your right arm and you're going to extend your left to balance that. These are reflex responses, and they happen in the spinal cord, not in your brain. Uh, it's still the central nervous system, but they are spinal reflexes. Okay, so when the pain fibers end up uh, in the spinal cord, they have to ascend to your brain, and the place that they go in your brain is the thalamus. And so there are connections between the the A delta fibers and the thalamus that is fast impulse acute pain, and that goes along the neospinal thalamic tract. It's the tract, it's the new tract, it's seen in higher animals, and it goes to the thalamus from the spine. The paleo, which means old tract, is the slow fibers, the unmyelinated C fibers, and it's the dull pain, and it still ends up in the thalamus. And the thalamus in the brain acts like the switchboard. It sends signals to various places from what's gathered in the thalamus. So it'll send signals to the primary sensory cortex to help localize the pain. It'll send to the limbic system that'll make you upset or afraid or have an emotional reaction. It'll send impulses to part of your frontal cortex, so you form memories of this. All of this. It also connects to a part of the brain called the reticular formation, which is the part that makes you conscious. It's the part that wakes you up, makes you pay attention. And that's why you wake up if somebody flicks your foot or, uh, you know, does something like that. And so in the spinal cord, just realize that they go from the spine to the thalamus. Higher animals, more developed, neo, lower animals, paleo. The new animals, like the higher evolved species, have both. Cool? And it wakes you up. So in the cerebral cortex, you have this from the thalamus, signals go and we locate in, and it's in the parietal lobe in the primary sensory area, primary somatic sensory area. From there, we have the association areas, and it's in the rear part of the parietal lobe. We go to the hypothalamus and the limbic system for emotional factors and to elucidate the whole stress response, and look for the danger. So we activate the sympathetic nervous system through the hypothalamus. And this is a connection from the thalamus. There's the we try and integrate the responses through the white matter of the brain, sending signals to a lot of areas, including the frontal cortex, which is your kind of conscious mind. We try and create memories for it, so that we learn to avoid such things again, right? And then we activate the reticular system through the reticular activating system, and that's in the brainstem, and that's just an awareness. You can be half asleep and calm as can be, and you know, and you get a painful stimulus, and you're wide awake, and your heart's pounding, and your sympathetics are in, and you're pissed off, uh, and you're trying to figure out what happened in your cerebral cortex, and you know exactly. It's like, why did you kick me in the shin, sort of thing. All happens almost immediately. So the stimulus affects the receptor, the afferent pain fiber goes through the dorsal root ganglion, uh, where it synapses, and it synapses with motor neurons here for the reflexes, and then it crosses over and goes up the spinal thalamic pathways, gets to the thalamus, and the thalamus relays signals to the somatosensory, to the limbic, to the hypothalamus, to the reticular formation. Like all of that happens out of the thalamus. And we become very aware of it. There is some research being done into maybe if people wouldn't be experience as much pain if we could interrupt this stuff at the thalamus. Uh, all kinds of ideas. Now, in the 1960s, there was two scientists named Melzack and Walls, And Melzack and Walls created what's called the gate control theory of pain. And it's a pretty accurate representation of what happens. It's its value is quite frankly in its predictive value and in its usefulness in pain management more than it is for its intricacies of physiology. But in any case, what Melzack and Walls said is that there are control systems built into pain pathways, that there are gates that allow the action potential to get through, and that you can modify the stimuli before it gets to your brain and you get awareness of it. So most of this takes place in the spinal cord. And what they're saying is that when the gates are open, the pain gets from that afferent pain fiber all the way up to your brain, up the spinal cord, up these spinothalamic pathways. And when the gates are closed, there's less transmission of that it reduces or modifies the passage of these pain impulses. And the reason being that the usefulness of the pain impulse is very quickly diminished. Once you have withdrawn and once you have immobilized, then feeling more pain doesn't have a lot of advantage. So let's moderate the pain and reduce the amount of pain that's being felt. So here's what it looks like with the gate open. So the painful stimulus affects the receptor, the peripheral fibers, the A delta and the C fibers, get to the spinal cord. Now it goes in the dorsal part of the spinal cord, not the ventral, like this picture shows. But within that spinal cord, a neurotransmitter is released from these pain receptors that's called substance P. It's released at the synapse. And the substance P is what then activates an action potential in these spinothalamic pathways. It gets to the RAS, the reticular activation system. Then it gets to the thalamus, and then it gets to your cerebral cortex where you perceive the pain. So there's a time lag between the painful stimulus and you actually perceiving the pain. And there is a break between the two sets of nerves that carry that, the peripheral nerves and the spinal cord nerves. There are also a bunch of interneurons that are in the area, but really do nothing when the gate is open. However, after that's been perceived, then what happens is there is areas in the brain that release endorphins and enkephalins. Right? And they come down, these neurotransmitters, really, endorphins, come down and they're efferent from the brain, so they're like kind of like motor neurons, right? And they affect these interneurons, which release the enkephalins. So cephalad means head. So these are coming from your brain. So the interneurons release this, and these are really opiates. Uh, endorphins are a kind of a natural opiate, and so the opioids actually block the pain in the same way, like morphine and things. And it stops the afferent fiber, the C and the A delta fibers, from releasing substance P. It blocks the release of substance P. So that means the substance P doesn't get to the transmission of the spinal thalamic pathways, and you stop perceiving the pain. Make sense? Okay, here's another interesting twist on it, that there are touch receptors that A beta thick receptors, but they are afferent touch receptors. They are from um, or touch fibers. They're from the touch receptors, from the Pacinian corpuscles and the Meissner corpuscles and that kind of things, that they transmit touch along from the same area as where the pain receptors are. When the touch receptors are stimulated, they interact with the interneuron to release enkephalins, uh, and will also block the pain. So what that means is that's why if you were like to cut yourself, it feels better to put pressure on on the wound. That the pain is somehow diminished if you suck on it, or if you kind of bite around it, or you rub it, or you put pressure. If you burn yourself, you like to rub it. If you bang your shin, you rub as much as you can in the area. And what that's doing is it's stimulating the touch receptors and the afferent touch fibers that cause the interneurons in your spinal cord at that same level, in that same dermatome, to release the enkephalins to block the substance P and close the gate to your perception of pain. Right? And there are drugs, as specifically the opioids, that also will block those receptors and uh, and block substance P release, and close the pain gate. So this really explains, like, just stuff that we naturally do, that we rub painful spots, that we uh, you know for that matter, it really means that if you kiss a boo-boo, it actually feels better, because that's a touch receptor being stimulated. Right? Why we rub or put pressure. Why a cut feels better if you put a Band-Aid on it, because then that pressure is maintained. It's and explains also how different uh, pain medications work. Okay, what are some of the characteristics of pain? We're going to be charting it. You're going to need to be able to talk about pain. Location of pain is a big thing. Where does it hurt? It hurts right here, and they point at it. If if they can't locate closely, then you might start thinking in terms uh, of perceived pain, or pain, phantom pain, or visceral pain, that kind of thing. People are notoriously bad at being able to describe pain. Uh, and I find that what ends up happening, and I'm guilty of this myself, because you can imagine that almost every single assessment that I've ever done in my career has been centered around this idea. You ask people to describe their pain, and they're going to be at a loss unless they're used to describing pain. So what you end up doing is you kind of give them a checklist, and then they just choose one off the list, which may not, they might just be trying to get you to shut up. So, but if you say, oh, look, is it aching pain? Is it burning pain? Is it sharp pain? Does it throb? Is it in a large area? Is it like a spastic pain? Like there's a cramp? Or is it constant? Does it come and go? Is it unbearable or is it moderate? Is it mild? You know, on a scale of 1 to 10, like uh, the problem is that probably by the time you get to sharp, they're like, yes, 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 it's sharp pain. Uh, so, uh, yeah, you'll be asking people to describe kind of the timing or the activity surrounding the pain. Like it hurts every time I take a deep breath, or it hurts if I try and sit up, or if I try and roll over, or if I flex my fingers, I get this pain in my forearm, things like that. The thing about pain too is that because it evokes the limbic system and it evokes the hypothalamus, you're going to get signs of it from sympathetics. So skin is going to go pale. They're going to sweat. They're going to uh, their heart rate's going to go up. Blood pressure is going to go up. All of the sympathetic, you know, the whole epinephrine, norepinephrine, catecholamine things that we've talked about before. And that's physical evidence. So one of the problems here is, especially if like we're dealing with WSIB or something like that, people can exaggerate their pain to as an excuse to get out of doing things, or you know, there's a lot of reasons. So you also kind of have to look for that physical evidence of pain. Like if somebody is telling you that their pain is a 9 out of 10 and it is sharp and aching and cramping, and you don't see any sweating or pallor, and when you take their pulse isn't up, and if you take their blood pressure isn't up, they're probably malingering. They're probably lying about it, you know? Um, the other hand, there's some people that are very stoic and they don't like to report, they don't like to admit that they're in pain, but the signs of the pain, like the signs that they're having a sympathetic reaction, are there. And you have to kind of go from there. Now, if the pain is really bad or if it's really unexpected, what you'll get from the sympathetics is nausea, uh, maybe even vomiting. Blood pressure changes can cause fainting or dizziness, and it feeds itself. There's anxiety. Um, One of the problems with anxiety is that a lot of the symptoms of anxiety are exactly the same as the symptoms of a heart attack. So if somebody gets some pain in the chest, thinks they're having a heart attack, then the anxiety of having the heart attack exacerbates the symptoms and the pain. Um, and so it can be really self-fulfilling. And you have to be able to kind of moderate that and figure it out to a little bit. Oftentimes on charts, there will be kind of grimace pictures. Then you check off what their face looks like. Uh, Rigid faces, clenched teeth, restlessness, guarding action is interesting, and you see this a lot. It's interesting that there's two fundamental types of spinal pain, and as a chiropractor, I dealt with it a lot. There is pain that originates in the disc, and there's pain that originates in the posterior joints of the spine, the facet joints of the spine. If it's facet joint pain, then it hurts to extend the back and stand up straight. So these people are bent forward. If it's disc pain, it's exacerbated by bending forward and it's relieved by leaning back. So just watching people get out of a chair helps me narrow down whether we're dealing with a discal problem or a facet joint problem. And then you look at the dermatomes, look at other things as well to go with it. And you look at their guarding behavior, like people limp or they move in very awkward ways, trying to guard the area. A lot of adults have got these kind of defense mechanisms around it. Kids don't. They have tachycardia and they cry and they have facial expressions, and you know right away that they're in pain. As children develop, they learn different coping mechanisms. They have a different range of behavior. They have trouble with communication, and they kind of want to withdraw. They don't want to talk about it because somehow that makes it seem worse. Sometimes they get it manifests as sarcasm or aggressiveness. When kids are in pain, they're not necessarily just going to cry and bitch about it. Little kids will, but older kids might just withdraw. I like to think of this as the same as animals. You know, like if your dog's in pain, they go hide. Uh, they don't bitch about it. You know, so it's much more physiological. Okay, I've talked a little bit about referred pain already. And referred pain is the problem is in one spot, but the pain is perceived in a different spot. And oftentimes, visceral pain, visceral damage will manifest as pain in other areas. So, for instance, problems with the gallbladder often are felt as pain in the right shoulder blade area. Problems with the heart are the left arm and the left neck and the left side of your face. Problems of liver end up kind of mid back, again, more to the right side. Kidney pain will be felt all along the front and down into your genital region, things like that. And it's very typical of where the referred pain goes. And so here's some of it here. So some of the pain is on the surface right above the problem. Some of it is in areas quite far away from the problem. And it really depends on the nerves and where the nerve, like for instance, that goes to that services the gallbladder, where it enters the spinal cord and where that dermatome that matches that level comes from. And so you'll often feel it quite far removed. So kind of knowing the map for can be useful in diagnosis. Phantom pain is a different thing. So phantom pain, the classic phantom pain is following an amputation. Uh, I have a patient that has been seeing me for about 25 years. I've known the guy quite well. He was a neighbor of mine for a while. And he was in an industrial accident, and he actually had to have his right leg amputated just below the knee. And he wears a prosthetic limb. And he's been complaining of phantom pain for the last 8 or 9 years. And at first, he thought and they thought it was a problem of the fitting of the prosthesis of the artificial leg. And it turns out it's not. So, what it is kind of scarring and difficulty at the remaining part of the nerve, stimulating action potentials in those pain fibers, uh, probably more the C fibers, the slow acting ones that are indicating that there is pain in the missing limb, because those nerves that end abruptly at the amputation used to go to an area further down the leg, to the ankle and whatever. And it's still mapped to the brain as that spot. And so if that nerve gets stimulated and has action potentials, it will fire and your brain will perceive the pain at the spot where that nerve used to go, even though that place is missing. And this guy has explained to me that the pain is one thing, the itchiness is what really drives him crazy because there's nothing to scratch. Like he doesn't have a leg, and but his leg is itchy. At least he perceives it as that. And he's been, and because he's been getting around the runaround from WSIB, he's been going everywhere to try and get this solved. And finally, he took it upon himself, and he just this past summer, because I still talk to him now and then. Just this past summer, he ended up going to Chicago to get surgery to really cauterize those nerve endings. And it's some special surgery that only a couple of places in the States are doing. It's experimental surgery. And it's so far, knock on wood, is working for him. Sometimes it resolves in a couple of weeks, but with this guy, it's been years and years and years, and it's quietly driven him crazy for quite some time. Like it's interfered with his interaction with other people. It's interfered with like you can just imagine the level of anxiety that it causes. Part of the problem is that they tried for about 4 years to save the limb, and before he ended up with enough necrosis that it had to be amputated. Uh, it was a crush injury, so intermittent ischemia and stuff, and it was so he had chronic pain there, and so when they removed his leg, his brain kind of was already accustomed to pain coming from there. And so that seems to make it more persistent. Again, it's not very well understood, but it's very legitimate. Okay, we've already touched on the idea of pain tolerance. So pain tolerance uh, is how much you can tolerate, not what you perceive, but it's uh, you can increase the tolerance by more endorphins, by the gate control, by drugs, right? You reduce it with fatigue or stress, and there are all kinds of supratentorial factors in your conscious mind, your perceptions and your expectations that moderate this, um, and and it varies in different situations, in different times, and uh, have a shitty night's sleep, and you're going to feel more pain because your tolerance will go down. Perception tends to be more consistent. And it's consistent across people, and but it's usually pretty consistent within a person. And so you can compare it day to day. It's and you have to be very careful when you're interviewing your patient that they understand that what you're asking about is pain perception, because that's uh, more of an indicator of healing or recovery if you are feeling less pain. And you have to be very careful because people will tell you how they're tolerating their pain. Uh, and it's a kind of a tricky row to hoe to, to hone in on what are you feeling. Um, so the tolerance really generates the response. This summer, I had a nephew, he's 4, and he got stung by a wasp. Uh, and I mean, it's a traumatic thing. He was playing and it was at my cottage, and he he got this sting. Well, you would think that World War III had started. Like, he was inconsolable. His response was over the top. But that's because he's young and he hasn't had very much experience with painful stimuli. He's also a very sensitive kid, and his personality goes into it. He's the firstborn, so his parents, my niece and her husband, um, are more indulgent, and so his response to the pain was huge. As he gets older and more things happen and he becomes less reliant on his parents, his response to pain will moderate, and it happens over time. And I think that's all that I need to say about that. Oftentimes, when we're very young or when we're very old, our responses to pain are more than when we're middle-aged and stoic. So we've already talked about acute pain. It's severe, it's sudden, it's usually indicative of tissue damage. Uh, for the most part, it's localized, but it can be generalized cases of like myocardial infarction and that kind of thing. Uh, there is uh, it evokes the stress response, so the sympathetics and cortisol and aldosterone, um, skeletal muscle tension, respiratory rates. Uh, it you very quickly shut down blood going to your GI, so vomiting might occur. The limbic system gets kicked in really hard, and so we have emotional responses to it because it's catching you by surprise. Chronic pain can wax and wane. It occurs over time. Uh, Usually, it's a pain in the ass to treat because it's not localized. It's not. Uh, a lot of times when you're treating acute pain, you're dealing with the sympathetics. You're dealing with with those kind of other aspects of the pain. The problem with chronic pain is that it can be a stressor, but even sometimes it's not that much of a stressor. So a lot of that, uh, a lot of times, the stress response is in the exhaustion phase. Um, Sleep disturbances are common. We lose the initial specific cause, it becomes less apparent. Uh, Appetite is often affected. People are irritable and depressed. The thing about sleep disturbances, people in chronic pain have trouble falling asleep. And it's a completely different thing than a sleep disturbance where people wake up from the pain. Oftentimes, that's more an acute pain. Uh, a very important bone cancer called osteosarcoma. It's the cancer that Terry Fox had. Uh, One of the things about that cancer is that it wakes people up. They will move in their sleep and then get sudden acute pain that wakes them up. Even though they have chronic pain that maybe is uh, preventing them from falling asleep. But it's important that when you talk to somebody about sleep disturbances that you specify is do you have trouble falling asleep or does this wake you up when you are asleep? Chronic pain, people avoid doing stuff. They require accommodations. So people with chronic pain of arthritis might need a walker or a cane, things like that. They walk slower. Uh, they can still have acute pain along with the chronic pain. Um, One of the things is that oftentimes when people have chronic pain, they have a lower tolerance for acute pain. It's like, oh shit, more, and yeah, that kind of thing happens. So the acute pain tends to be uh, for warning, it's localized, it's fast, it is the A delta fibers, it's often mechanical or thermal injuries. It goes up the neospinal thalamic tract. Uh, Short term, sudden, you get sympathetic and uh, adrenal cortex things. If you can remove the cause, you can intervene. Treatment is very effective. Block the production of prostaglandins and things like that. Um, it really helps. Slow, diffuse pain is chronic. It's from existing injuries, from chronic injuries that where there's histological change. Uh, Tends to be slow C fibers, paleospinothalamic tract. Uh, it's disabling. It leads to emotional distress, depression, irritability, uh, and it's very difficult to treat. There's a We could do a whole course just on headache. There's a bunch of different types of headaches. There's Some of them are quite common, some of them are fairly rare. Most of us have had headache at some point. Um, so there's the headaches from problems with pressure in your sinuses and in your nasal passages or eye strain. So these tend to be headaches in the front of their, like the frontal bone around your eyes and the orbits, maybe down even into your teeth. You know, in your cheekbones, and so your your frontal sinuses, your ethmoid sinuses, your sphenoid sinuses um, get congested and can give this kind of pressure filled uh, things. Often it's got to do with rhinoviruses and inflammation, uh, viral infections, that kind of thing. Tension headaches from muscle spasm often are from like clenching your teeth because you're upset. Your emotional distress. You The muscles of your scalp and facial expression uh, have too much tension in them, and you'll have uh, pain from that. A lot of times, the pain headache in the temporal region comes from chewing and from a problem of the TMJ. TMJ problems are really, really common. It's a complex joint that takes a lot of abuse, and a lot of people have problems with it. And so there will be this pain kind of like in front of the ear from it. Migraine, I mean, there are migraine headaches, but migraine is really a vascular problem. Migraine, what it really comes down to is you have abnormal blood flow to the brain. It's usually somewhat diminished for whatever reason, either like it's vasoconstriction because of triggers, uh, cheese, caffeine, things like that. Um, or it can be a mechanical thing from osseous alignment and tortuous routes to the brain. Either one, what happens is the brain starts to get a little bit of ischemia, especially in the occipital lobes. And then your vision kind of goes wonky because you've got less oxygen going to that part of the brain, and the occipital uh, visual cortexes is usually the first thing affected because it's often the vertebral arteries going up through the foramen magnum. And so what happens then is protecting your brain at all costs is a very important thing. So what happens is you massively vasodilate uh, to get more blood to the brain. And literally more blood goes into the brain and you create more cerebral spinal fluid and you increase the pressure inside the skull and your brain gets too big for the size of your skull and you get these massive headaches and the brain pushes down on a lot of the cranial nerves, especially the optic nerves. So you become very photophobic and you get this pain uh, from this intracranial pressure, really, almost like an edema of the brain. Intracranial headaches are anything that causes an increased pressure inside the skull, production of cerebral spinal fluid, or uh, a blockage in the reabsorption of the cerebral spinal fluid, so the kind of hydrocephalus. There's a fine line here between migraine and intracranial headaches. So oftentimes intracranial headaches can come from a trauma and a hematoma in the meninges, so a subdural hematoma and that kind of thing. Concussion causes inflammation, especially in the meninges, and that will increase the pressure inside the skull. And so that would be intracranial pressure headache. So that would be considered like central pain. Neuropathic pain is, so that's neuropathies caused by something that's involving the peripheral nerves, trauma or disease. Oftentimes, people with diabetes, because that affects the small blood vessels in the periphery, oftentimes get ischemia and end up with neuropathic pain along that. There's ischemic pain, so that would be things like angina and things like that. There's cancer-related pain from the size of the tumor or tissue damage from especially lytic tumors. And we spend a lot of time and we spend a lot of money managing pain. So the most important thing to manage pain is remove the cause of pain as soon as possible. So if the pain is from, I don't know, a splinter, then getting the splinter out will help right away. Algia is pain. So analgia is removing pain. So analgesics are medications that remove pain. You can take oral analgesics, the nonsteroidal anti-inflammatories like Advil and things like that, block the production of prostaglandins, antihistamines, block histamine and that kind of thing, reduce inflammation, and can be used to manage pain. Sometimes injection works much faster. Chronic pain, oftentimes transdermal patches work. So fat soluble, a patch will help manage pain. We use different drugs for different pain. So mild pain would be maybe Tylenol and Advil, that kind of thing. Moderate pain, we start to use more invasive drugs. Severe pain, the opioids and things like that. So the non-steroidal anti-inflammatories, Tylenol, aspirin, they reduce fever, they are anti-inflammatories, and they stop the production of prostaglandins, and that's part of their anti-inflammatory action. Moderate pain would be like Vicodin and codeine, oxycodone, Percocets. They work on the perception of pain. So they're involved with that gate control, the enkephalons. So oftentimes we do like codeine and acetaminophen together, those sorts of things. So Tylenol 3s and that are used in moderate pain. Severe pain, morphine, Demerol, oxys, they work on the central nervous system. One of the problems is they're addictive And you also have to be careful because it depresses respiration. And any of these things, so the codeine and like all of these things also constipate you. And so that can be part of management as well. Useful for managing pain is also sedatives, the anti-anxiety drugs, because they don't stop the perception of pain, but they help with you coping with the pain. So it's it's changing the tolerance. And so if you can change the tolerance, you might get away with less of the analgesics. So people develop tolerances for their pain medication over time and the chronic pain. Uh, and so that's something that has to be managed as well. Sometimes just changing drugs uh, works. Uh, Patient-controlled analgesia, PCAs, is when they push the button and a bolus of, it's usually for severe pain, patient administered. Uh, and what the idea is that they only take the medication when they are feeling it, so they will use less. And the narcotics being addictive, that you want to use less. Um, Sometimes pain can't be controlled with medication, and so literally they go in and they cut those nerves, uh, and they can do surgery. You can do injections that deaden the nerves. So that would be things like even like Novocaine and that kind of thing temporarily. Um, Muscle pain is a whole different thing. We use Botox and corticosteroids for the injections, and we go into the trigger points, areas of spasm, trying to break that up. And uh, TENS is a useful thing for managing pain as well. And this is really electrical stimulation, and it it tricks the nerves because it causes action potentials in the nerves and causes the inner neurons to release the uh, enkephalons to manage at the gates. Uh, yeah, all these things have their uses, and usually there's some sort of a concerted use of all of these things. Anesthesia can be local, uh, can be just a rub on, or it can be an injection. Spinal blocks, general anesthesia makes sense, right? So here's the local anesthetics, the general anesthetics. Spinal anesthesia is the epidurals that they give during childbirth, blocks nerve conduction below the level of the injection. Right? So all of these things are useful and help manage pain, which is really a major part of healthcare delivery, helping people manage their pain.